Good evening, everyone, and a warm welcome to you all. My name's Professor Dylan Edwards. I'm the Pro-Vice Chancellor of the Faculty of Medicine and Health Sciences, and I'm really pleased to welcome you here tonight to hear Professor Kristy Sanderson give her inaugural lecture. Kristy joined UEA a year ago now, in January 2017, as Chair of Applied Health Research in the School of Health Sciences. She trained originally as a psychologist in Sydney, Australia, and had a brief clinical career, completing a PhD in 2001 from the School of Psychiatry at the University of New South Wales. And then she had postdoctoral positions in public health and epidemiology in Sydney and in Brisbane, and a stint at the World Health Organization in Geneva, working on the Global Burden of Disease Cost-Effectiveness Study. Prior to joining UEA, Kristy was a Principal Research Fellow at the Menzies Institute for Medical Research, University of Tasmania, where she established the Public Mental Health Group in 2006 and then went on to lead it for 11 years. Reflecting her interdisciplinary approach, Kristy has held personal research fellowships from the Australian National Health and Medical Research Council, the NHMRC, and the Australian Research Council. And prior to joining UEA, I should say that Kristy was continuously funded by the Australian NHMRC for 17 years. Knowing the competition in these big national funding agencies, that's a fantastic achievement right there, just to hang on to the money that long. So Kristy's worked with employers and staff across the public and private sector on ways to promote their own health and well-being. She's led advocacy work on workplace mental health and been part of the National Expert Advisory Group on workplaces with the Australian mental health charity Beyond Blue. Kristy's current research explores how to promote good mental health and prevent mental health conditions in the healthcare workforce. In a lecture this evening, Kristy will be looking at job stress in healthcare work, and in particular within the NHS. In this talk, she'll explore possible causes and what might be done about the problem. Is it a matter of more money and more training, or is there a need for a fundamentally new approach? How can systems be made more robust so that workforces are better supported? And how can we better prepare the next generation of healthcare workers? So please join me now in welcoming Professor Kristy Sanderson to give her inaugural lecture, Money, Mindfulness, or MBAs. Welcome.
Thanks very much, Dylan, and it's absolutely wonderful to be here and to see so many of you here on a wintry Tuesday night. I want to say a particular thank you to those who are joining on the live stream that's going out. If any of my Australian connections have woken up really early, please go back to bed. You can watch it later. And yes, I'm talking to you, Mum. Okay, so as Dylan said, I've kind of got three broad issues that I wanted to explore in the next 40 minutes or so. And I really gave the title to get us to talk about the challenges and tensions that we have in what we know is a hugely important topic. We've had the media full of it at the moment with winter pressures on the NHS. So is it a matter of simply more money? We know more money has to go into this system. Every time this gets looked at, the gap between actual expenditure and what's required is real. But is it a matter of just higher pay for staff? Where would we put that extra money? And what else do staff value? What's going to help them cope in a stressful system? What's hugely popular at the moment is wanting to make all staff resilient. Is that all it's going to take? We just need to make people able to wear the pressures of working for the NHS. It's appealing, but doesn't that put the emphasis on the individual? What about looking at the system that they work in? And part of that is to look at upskilling our managers and leaders. Are they really trained for the job that they've got at hand now? And it was really pleasing to see in the last week a new initiative that's come out of the Norwich Business School here, working with the NNN and other partners to really see how we can develop our leaders to meet the challenges that are here right now, not just the challenges that are coming. So what I'll run through this evening is really to give you my perspective on where we're at with stress, health and wellbeing of NHS staff. So I'm not really a new arrival now. Been here a year. I'm not you, but I can look at it with fresh eyes. I haven't lived in the UK before. I haven't worked in the NHS. So I can look and have a look and say, what are the issues? What does it seem to be being done about it? Then I'll just do a little bit of theory, not too much because it's an evening lecture and we've got wine waiting. We don't want to spend too much time on theory. But in terms of what's being done, does that really match the international evidence-based practice that we know should be done for workplace health and wellbeing? How are we exploring whether current initiatives are actually making a difference? And I'll talk through some new work we're developing up with the Ambulance Trusts of England and Wales that we and they are very excited about. And then I'll briefly conclude with looking to the future, because of course it's one thing to help the staff that are in the system now, but how are we preparing our next generation of healthcare workers? And can we have an articulated response that goes through the whole working life, from day one when they turn up to university to when they're out there being future leaders? So firstly, I want to acknowledge, of course, that my career has been built on for what for me has been an extraordinary, lucky career where I've got to work with some fantastic people. I've had some very positive and supportive working environments. And I particularly want to thank the PhD students that have worked with me over the years. There's been 12 of them. Some of them are in that picture, and I'm going to highlight some of their work and how it intersects with my thinking of what I'm doing here at UEA. That was my farewell party, by the way. That was early in the evening. Later in the evening, the photos weren't so good. So this is an area that all of us have intense buy-in, particularly those that work in the NHS. This affects you every day. So I've just got a couple of slides of terminology to just run through and sort of clear up a few things about when I use these terms, what do I mean? Job stress simply we can think of as the experience of too much pressure without the opportunity to recover. So that's it at its heart. We have 30, 40 years of research on job stress. We know a lot about it. We know an enormous amount about the stressors on people working in healthcare systems. How are we making that link to actually getting effective change in workplaces? Again, we have decades of research on what the consequences of job stress are, and they are broad. Some of these effects are fairly modest, but if we think about how many people get exposed to job stress, when you add up all those little differences in terms of impact on health, the burden really is enormous. So for the individual, we see physiological, behavioural, psychological consequences that lead to increased incidence of health conditions such as depression and cardiovascular disease. So the effects are real. For the workplace, we see impact on absenteeism, turnover. We've all heard about retention issues in the NHS, particularly nursing workforce at the moment. Worryingly, it's associated with errors, people under pressure who are not supported. It's not a surprise that mistakes can be made. But it also impacts on lack of innovation. If you've got an environment where people can't speak up, where they don't have time to think clearly, it impacts on the ability for healthcare to be the most innovative it can be, and to actually adopt those new innovations that are coming out of the research pipeline. So the effects are broad, which is why we care about it so much. When I'm talking about outcomes, I will kind of dip into talking about mental health, talking about mental well-being, talking about mental disorders. So broadly, mental health, when I'm referring to it, is psychological and emotional aspects of well-being. Mental disorders, where I'm talking about the clinical manifestation, where someone has moved into a prolonged collection of symptoms that meet our current diagnosis for mental disorders. And well-being is our broadest sense, our broadest way that we can capture how work impacts on our lives. And one definition that I really like is well-being is it's not about making everyone happy 100% of the time. That's just simply unrealistic as human beings. What we can hope for is a state of balance, where you have sufficient resources, be they social, psychological, economic, to meet the challenges you face. And those two parts are critical, because if we think about how can we best promote well-being in our NHS workforces, have they got the sufficient resources, wherever those gaps are, and are we managing the challenges that they face? Because that's a legal responsibility for employers to provide a safe workplace, including a psychologically safe workplace. It's not a nice added extra in the good times, it's a legal responsibility. Okay, so let's have a look at my view of what I think is going on in the NHS at the moment. So I'll just dip into little bits of stats that have caught my eye over the past year to show how they've influenced the work program that we've begun here. So my first question when I arrived, is there an appetite for this in the UK? Is mental health in the workplace on the agenda? And it absolutely is. My timing in some ways was perfect. Just a few months ago, the government released a new report looking at mental health and employers. And I think that title, Thriving at Work, is really important because it's looking at both reducing risk to people and looking at how workplaces can make people have positive experiences. But of importance to the NHS is that the government response on the day that the report was released and got huge media coverage was that the civil service and the NHS will now have guaranteed tailored in-house mental health support. So some of you, if you're working in the NHS and you're feeling well supported, will think, well, we've already got that, but we know a lot of places do not. And what's important is both the civil service and the NHS are going to be held to all 40 recommendations of the report. I'm not going to go through them now, but I would definitely say have a look at this report because this is what's coming for the NHS. This is required to be implemented. So who's responsible for workplace mental health and wellbeing? This is my next question. And boy, is it a busy space in this country. It's fantastic, but there is so much going on. It took me a while to really try and put together all the players that were in this space. The NHS itself has been involved in this, of course, for a long time. There was a huge push 25 years ago when yet another report came out saying more had to be done for staff health, and it has been coming to the top of the agenda regularly. Public Health England has a role, NICE has a role, NHS Employers has a clear role. We've now got the NHS Health at Work network after the Borman review to see how occupational health services could do a better job. They've now got new voluntary standards to work for. Then we've got the Health and Safety Executive, which is really the administrative and monitoring arm for reducing psychological exposures that harm in the workplace. And then we've got the great innovations that have been coming out of the charity and business sectors. Mind has been active in this space for a long time and have done some hugely fantastic work. We've got the Workplace Wellbeing Charter, which is just being revised, but that's how businesses and organisations can do a self-audit. So we have got a plethora of choices for looking at how we can support staff. So how do we know what's actually being done? And again, those of you working in the NHS might groan when you think, oh no, she's going to talk about the staff survey. But I'll tell you with fresh eyes, this is an extraordinary initiative that the NHS has been doing. It's just done its 14th survey. It's incredible. Every year in NHS organisations in England, more than 400,000 staff do a survey of their work experiences. So in terms of scope and scale, it's one of the largest employee surveys of its kind in the world. And of course, being an epidemiologist and loving data, the first thing I thought of was, wow, look at this extraordinary data source. How well is it used and what is it telling us? And it covers some really key things that we know are important from the job stress literature. Negative experiences at work, so the big ones are bullying and harassment, but also experiences of stress-related illness. So if you experience stress to such an extent or to such a period that it's now making you sick. Importantly, it covers those positive experiences, so things like support from colleagues, a well-functioning team, a manager who seems to know what they're doing. It covers staff's perceptions of care quality and patient safety. Can they do the job that they want to do? And it looks at organisational support for staff health and wellbeing. Again, what are the staff saying on the ground? How do they perceive the support that they get? So I'm just going to give you a few things that caught my eye. An enormous amount of the results that are put out focus on engagement, which is a composite score from 3 things. Would staff recommend the organisation as a place to work or be treated? How do they feel in terms of their motivation at work? And do they feel able to contribute towards improvement at work? So important, yet it might seem such a simple statement, but are they empowered and do they feel that actions follow when they speak up? So this is a very simple scale, more is better, and you can see that gradually that's been increasing over time. So tiny changes, but again, large numbers over a population level, this is statistically significant. So you think, great, staff are feeling more engaged, that's got to be a positive. If we have a look at how that breaks down by where staff are working, we can see that overall there's not a lot of difference, except we see a bit of a dip there for ambulance trusts. And that's one of the reasons why that's become a focus of my work for the past few months. And I'll give a little bit of a description of the work we're doing in that space. I pulled out this one because this is an area that I've been working in for quite some time. So percentage of staff attending work in the last 3 months despite feeling unwell because they felt pressure from their manager, colleagues, or often themselves. People who choose health careers usually have a very strong bond with their workplace, with their patients, and they don't want to let anyone down. That means when they get sick themselves, they have a stronger tendency to keep working when they're sick, when they should actually be taking a step back and having time for self-care, So you can see again, this is slowly going down, which is fantastic. But even in the last lot of survey results, we've still got more than half of staff saying that they've had this experience, and that is high. I've been looking at presenteeism results for a long time, and that is high. Now I'm just going to give you a few sort of local flavour. So I've just picked out, I'm obviously not going to identify them, even though this is all publicly available, just to show that there's some great stuff happening in our region, and there's also some areas that we need to work on. So here's an example organisation from East of England. They've got a number of areas where they're improving. Fantastic, this looks really good. Important things like some support from immediate managers, recognition and value of staff, organisational and management interest in taking action on health and wellbeing, so important. But this organisation has also got a couple of areas where they've got worse from one survey to the next. And they're what we might call our big ticket items, those that can have profound impacts on staff members' health and wellbeing, experiencing discrimination and physical violence from staff. They also look at physical violence from health service users. Thankfully, that physical violence from staff is a small baseline, but it's going in the wrong direction. So that's something that you would clearly be concerned about as an organisation. Another one, they've got some areas where things are trending in the opposite direction. Here we've got that presenteeism one that we were just looking at. The trend across the whole NHS is things are getting better, but not at this organisation. It's trending in the opposite direction. And again, we've got another big ticket item, harassment, bullying or abuse from patients or relatives in the last 12 months. So this isn't just an issue for the NHS, it's not just an issue for the charities that work in this space, this is an issue for every single person that uses a health service. And just another organisation where unfortunately this one had a big long list of things trending in the direction that we wouldn't like. So clearly we have some local challenges we can look at. The last bit of data I'll show you from the NHS Staff Survey is a really big one and important one for me. Simple question, does your organisation take positive action on health and wellbeing? These data points show each of the 316 organisations that participated, so the aggregate for each of those. Overall, 32% of staff said, yes, definitely, my organisation takes positive action on health and wellbeing. Go back to something I said earlier, the NHS has had a massive push on staff health on and off for 25 years. Barely a third of staff are perceiving it as a priority in their organisation. I find that extraordinary. So what's going on? Is it a matter of perception? Is it a matter of there's a good narrative at the top level, but down on the front line, that's not what staff are experiencing? So the NHS Staff Survey, again, I'm impressed and I'm a fan, but there's a lot of stuff it can't tell us. I was really surprised to see that there is the routine analysis that is done of this extraordinary data set is actually quite limited. There's some good reports that go down at trust level, but not much actual research engagement with how these experiences cluster together. Is there a tipping point of positive and negative experiences where people start to get at risk? How do they change over time? Incredible resource that we need to make more of. It's starting to happen. I want to highlight work from colleagues here at the Norwich Business School that published this last month. People are starting to engage with this and realising what an incredible resource it is. They did some really neat analyses trying to look at what was causal over time. Staff are asked about their perceptions of care quality and safety, but a couple of researchers have taken it further and said, well, does that actually correlate with what's happening at trust level in terms of care quality and safety indicators? So a couple of years ago, a large-scale project was undertaken looking at all of the data and then looking at some hard endpoints in acute trusts. Mortality was one. And yes, there are some trends of relationships, but they pointed out these things are complex, particularly when you're looking at variation in patient outcomes and variation in mortality. This is one part of it, but you need to look at it in terms of the system complexity. A couple of other key points. This is a survey of staff experiences. Apart from a couple of items related to health, it doesn't actually ask staff much about their health. So we know these staff experiences are critical for health, but the survey doesn't actually tell us much about that. We also don't know the specific initiatives that are being offered to support staff health and wellbeing, whether staff use them, whether staff find them helpful. These are simple questions but are critical. How can you know where the gaps are if you're not seeing what people are using and what's being made available? So we learnt this just before I moved here. We're just at the tail end of a 5-year project where we went into a defined public sector, the Tasmanian public sector, employs 30,000 people, so nothing compared to the NHS. But we had great access. About 40% of the people in our study were from the health and hospital sector. And we went in and the government was telling us what they did, which all sounded fantastic. We have these programs, it's been a priority, we're targeting staff stress and mental health. So we went all around our state and asked our staff, well, what were they seeing? Were these programs available? Did they use them? If not, why not? And you get a completely different picture, of course. What's understood at the top level is not always what's understood at the front line. And this gave us some really good clues about where the gaps are in terms of actually getting staff to use things even when it is available and when it's offered. Because the barriers really are large. Number one is always time. Sometimes that's a perception of time. But programs might be run at lunchtime. It's not going to work for shift workers. It's run in a central location. People out in regional areas can't access them. Some pretty obvious stuff. But also I wanted to highlight, of course, as a researcher, I'm going to say this, routine data is fantastic, but sometimes if you bring researchers in to look at a question, we can get a bit of a different story. And that project in the public sector I just mentioned, we actually were able to compare this. They too did routine surveys of staff. They were actually looking at health indicators this time. We came in and did our survey as independent researchers. We actually got similar response rates, but the people we attracted to do the surveys were different, which meant the story we got were quite different. As it turns out, the routine employer survey seemed to overestimate rates of poor mental health, especially amongst men. And when the researchers came in and did a survey, we actually got a closer estimate to our best guess of a regional benchmark. So while routine data is powerful and really important, there's always going to be a role for the researchers. And yes, of course, I'm going to say that. Okay, so that's just a bit of a snapshot, and a lot of that won't be new to you. But now I want to turn to say, well, we're kind of starting to get an idea of what the issues are. We're starting to get an idea of where the gaps are in terms of knowing what's done. How does that match up to what the evidence is telling us should be done? And here I'm talking about the international evidence base. So this is where I'll introduce a framework that I've been using for some time. It's been around in various guises for a while. It's called the Integrated Intervention Approach to Workplace Mental Health, or the Integrated Approach. It's called integrated for a number of reasons. It draws across a broad range of disciplines, which I think is absolutely crucial for this topic. Job stress is not the responsibility of any one discipline or any one organisation. It's a complex, messy problem that needs us all to work together. So this brings together the best of what we know from the past 30 years in terms of how we prevent stress in the first place and how we prevent those consequences we talked about. What I've become increasingly interested in is how we promote the positive in workplaces. That's so critical. If we spend all our time talking about what's wrong, we lose sight of what's working and what people actually love about their jobs. But critically, we can't forget that we need to have systems in place to encourage people to seek help when they need it if problems are developing. So you can see from those list of disciplines, this is drawing together an immense literature base and simplified it down into 3 nice target areas. So preventing harm, that's doing things like targeting work-related factors that we can change. We can't change everything, even with the best of intentions, but we can change those that we can. Promoting the positive is looking at worker strengths and positive capacities, how teams work together, how individuals interact in organisations. And managing illness, again, is looking at those mental health problems. And that's where we have to step back from cause. What if something's happened, a workplace is required to deal with it? We then don't need to have this conversation, or was it really a cause of work? We just need to manage it appropriately. This is a huge agenda, so of course this needs to be unpacked at an individual organisation or sector level to see what's being done and already and where are the gaps. So one of the projects I did just before I left was to take this massive agenda and try and have a national conversation about what our priorities for action should be. There is so much that could be done. So we convened a national meeting where we had representatives across the spectrum. So this was looking broadly, public, private sector, charities, unions, employee representative organisations, to get people around the table for a day and a half to distill what we really think are the things we should be focusing on in Australia for the next couple of years. And this was fantastic, I will say. I want to let the participants speak in their own words, so I've just got 3 quick slides to say what they brought up as the issues that they thought were the things that really need to be focused on. And when we have a look internationally, similar themes are coming up. There may be inter-country differences, but these are pretty universal for people in modern workplaces. So when people were asked to nominate, well, how do we prevent harm? This on its own is a massive agenda. We need meaningfulness at work. We need leadership modelling the results that they want in terms of their culture. How to give and ask for social support, valuing social connectedness. Justice and fairness in procedure and practice as part of the culture. And again, this can be built into the way an organisation works, and we have ways of measuring that. The group kept coming back to the role of middle managers, or line managers as we might say. Often they're the ones that are having to deal with this on a day-to-day basis. How well are they skilled? And trying to build in incentives for managers to engage in this. We've come a long way in the 15 years I've been working in this space. So we don't usually have to have the conversation anymore that this is important. So we've won that battle. The conversations I was having 15 years ago would have horrified you. So we've come a long way, but still we need to kind of incentivise this in workplaces to help keep it towards the top of the agenda. Promoting the positive. This was a really nice discussion to have. Of course, resilience is going to come up here because it is important. I don't want to minimise it. It is important to have. It's about people's ability to bounce back, to learn from challenges. But again, we come back to this notion of connectedness, positive leadership. How do we actually develop frameworks and supports to make sure this happens routinely in workplaces? And manage illness, again, a lot of the work in this space has gone into this, so I'll talk less about this, but it has been critical, and there's been some wonderful work to see how can we actually reduce those barriers for people to seek help in a timely manner. How do they have those conversations with their boss? Again, just before I left, the big, large national charity I was working with, Beyond Blue, rolled out a deceptively simple tool, but was wonderfully received. It was a little decision tool to help employees make that decision of should they tell their boss about why they've been having so much time off. Should they actually disclose that it was for their mental health? Because even though a lot has changed, we know some people are in environments where that disclosure will actually be very damaging to their career and to their long-term prospects at that employer. So again, coming back, this is a large, complex agenda. So what sort of tools are already in place? So coming back to one of our wonderful students, Kate, when she started, that was her question. Well, what do we already do? There must already be guidelines for employers, guidelines for different settings. There must be how-to manuals for workplaces. And yes, there are. So we went off and did a review of all the international guidelines we could find that looked at workplace mental health. And we mapped them against this integrated approach. How well are they actually doing? The number one actually came out of Canada. The UK resources were not far behind, but they needed to be doing a little bit more on the positive space. We can see that changing now already. But Canada's really been at the forefront of this for a long time. And they do have some incredible resources if you ever looking for some quiet reading on a weekend. Another student of ours, Larissa, who's currently still in the middle of her PhD, she's really wanted to drill down into what she sees as a potential powerful force in workplaces that has a lot of traction in public discussion, in media, but it's potentially really, really powerful because mindfulness training has the potential to prevent harm as well as promoting the positive. So here's one intervention that could actually help us address 2 parts of this agenda. Many of you will be familiar with I've called it hype, which is a bit unfair, but it is very much in the consciousness at the moment. And that's arisen for very good reasons. In clinical populations, there is good to very strong evidence that it improves outcomes, prevents recurrence of depression, helps people manage pain. A whole lot of settings it's been shown to work. But it's crept into a whole range of non-clinical settings like workplaces, and we have to ask the question, is it actually achieving the promise that's been made? And this is important because mindfulness training might seem fairly innocuous, but it can actually cause harm for some people. There are people with a certain collection of experiences. Trauma is one of them, where just off-the-shelf app-based mindfulness can actually cause a deterioration in their mental health. So it's not an innocuous intervention. So Larissa's been exploring whether training is effective for a relatively healthy working population. And she was getting a lot of traction with this. She's done this amazing review looking at the quality of the evidence and really unpacking where the gaps are, which she had great reception at a psychological conference middle of last year, where she won a Best Paper Prize, which of course as a PhD student is extremely exciting. So when she pulled together all the trials that have been done in working populations, there is good evidence for some outcomes. People do have a greater sense of well-being. They do report lower levels of distress. It helps with sleep, and we know from some studies that's due to the fact that it reduces rumination. When you're waking up at 3 a.m, where your mind is just spinning, mindfulness training can help with that. What we found, given all of the hype that's in the sort of current media, was a surprising lack of evidence for job stress and work outcomes. There's really only a very small number of studies that have looked at this, and the effects are quite equivocal. Whereas if you type in mindfulness in workplaces, you can probably find hundreds of providers, well, I know you can, provide hundreds of providers that will sell it to you on the basis of improving productivity, but we actually don't have the evidence for that yet. Another key limitation is that, as with a lot of psychological research, it of course relies on people's perceptions of their own behaviour and their own sense of well-being. But we can actually be a little bit clever and ask their colleagues and friends whether they're observing any changes. And so Larissa's gone off and developed a measure where she asks people's workmate, family member, to observe and see whether they think the person is becoming more mindful. So it's really neat because it gets around one of the big criticisms of mindfulness research, that yet another psychological approach that relies on self-report. Larissa's getting some wonderful data about this to show where there's agreement and where it seems that perhaps people aren't having the best insight of what's changing. Because if you're participating in an intervention, you want it to work. There's a big incentive to say, I feel better, this is really helping. So this study is open internationally. She's got people participating from anywhere. So if you have any experience in doing meditation, you're welcome to go on and have a look at her study to see if it's something you might want to do, bearing in mind that you have to rope in someone who's willing to observe you. And following that, Larissa will be taking it out to frontline public sector workers. So again, she'll be looking at those that are at high risk. That's healthcare workforces, teachers. And she's working with quite a nice little Australian company that again is available internationally on yet another of these mindfulness apps. But they've built in some really nice tweaks and training videos and exercises. So we'll ask those questions that haven't been asked yet. It seems like an easy win, but is it actually making a difference? Is it changing people's perceptions of their work environment? Are these sort of approaches actually cost effective? And are they acceptable amongst a higher risk workforce? Because not everybody's going to engage with this type of approach. So now we'll take it back to look at one particular area I've been focusing on for the past couple of months, to help us start to address the question of whether the current initiatives are making a difference. And I'll talk about a project that we've been developing up with the Ambulance Trusts of England and Wales. This is very timely. Some of you may be aware this week is actually Ambulance Health and Wellbeing Week. This is really nice that this is a positive discussion that's happening for ambulance trusts this week. They've been under a lot of fire recently. So this is an opportunity to spend a week focusing on staff welfare, but also what's good, and really to make this a community conversation that everybody has a role in helping our health workforces be the best they can be. So this has had buy-in, obviously, from all the major players that are there to support staff wellbeing. So why is this such an issue? Just broadly, we already know from the international literature, just to look at some of the negatives that we know from working in an ambulance trust. Higher rates of PTSD, post-traumatic stress disorder, than police or firefighters, which are emergency services they're often compared to. Higher rates of suicide, lower help seeking. There's going to be a whole lot of reasons underlying that, one of which is that researchers and organisations have been involved in health and wellbeing for police and firefighters for a long time. This is really quite new for the ambulance workforce. When Lucy and I started pulling together the literature for this, it was astonishing how little there actually is, and it's not really moving forward in terms of testing innovation. So we've got a bit of catching up to do. So this is looking across the country. Let's have a look at a couple of ambulance trusts and see how they seem to be travelling. I said I wouldn't show you any more staff survey data, but I actually am. But this is quite focused. Green means good. There's good stuff happening. Across a range of areas, looking at role of appraisals, able to contribute to improvements at work, agreeing that their role makes a difference to patients and service users. So critical in terms of having pride in what you do. But we also know that some trusts are struggling in this space. They're doing worse than the average. Physical violence, where they're actually able to speak up about their last incidents of violence, harassment or bullying from patients and from staff, and whether they actually feel able to report that. So there's some real barriers in this space at the moment. And when we started talking to people across the sector, this one really stood out for me. So this is a conversation I had with a senior paramedic, who's male, from an English trust. Management know what the problems are, but they are paralysed about how to deal with it. So you remember one of those slides I showed early on about how many players there are in workplace mental health? They're all there for ambulance trusts as well. But from this paramedic's perspective, there is no strategy. So our question, and we heard this in various ways from various trusts, our question is that actually true or is that a perception? Where are the gaps and where should we be focus our energies to really improve things for staff and crucially to improve patient outcomes, because we know that link is there. So we started off hoping to involve 3, maybe 4 trusts in what we were trying to do, and it was all in. It got very big very quickly. So all 10 ambulance trusts in England wanted to participate, as well as the Welsh Ambulance Service. So we suddenly had a very big study on our hands, which was fantastic, but meant a lot of running around and a lot of late nights. Thanks again, Lucy. So the study that we've been developing is Work, Health and Wellbeing in Ambulance Trusts in England and Wales. It's pretty simple, strengthening staff supports for improved care quality, because this is at the heart. So rather than trying to get a trial of the latest innovation, we wanted to step back and say, we know there's a lot of stuff going on, but it's not being evaluated and we don't know where the gaps are. So let's start there. And thankfully, the national players in this space thought that this was also a good idea. So there's a lot of initiatives coming, but they were actually delighted that somebody in the research community was deciding to tackle this head on and do a large-scale project on it. So we've had fantastic buy-in from all of the national organisations that are playing in this space. Our questions are pretty simple. You'll have seen they look pretty much like the ones you've seen I've been interested in before. How do positive and negative experiences at work relate to care quality and safety? What are ambulance trusts currently doing to support staff across their whole workforce? This isn't a paramedic issue, even though that's really important. It affects the call handlers, it affects the operational staff. Is what they're doing matching best practice? Again, it's critical to get the perspective from both the trusts and the individual staff. If trusts think they're doing everything they can, but staff are saying, no, you're not, why is that and why is there a disconnect? We want to see the extent to which the integrated approach has been implemented. We know they're talking about it, we know they're interested in it, to what extent it is actually making change in individual trusts. And we'll do that through a variety of ways, policy review, in-depth interviews. Because what we're trying to distill is, where is that best practice? They keep telling us it's there. Where is it? Why is it working? And how can we replicate that nationally? So coming back to theory again, this looks really busy, but what I would just want you to take away from this is that we've got the research tools to do this at scale. We can look across our 3 areas of preventing harm, promoting the positive, and managing mental health conditions. We've already got some of this data, and we've got ways to fill the gaps. Everybody has a role in this, critically within an individual trust. Senior managers, line managers, health and wellbeing managers, individual staff. Everybody has things that can be done. We want to understand why staff are saying there's no support available to them when their trust is saying the support is there. Who is it getting through to and who is not having access? And a trust trying a lot of stuff but don't have mechanisms to tell them what they should continue and what they should actually drop. And those last 3 columns are those broad range of outcomes I've been talking about. We have ways of capturing these and really seeing what these pathways to better patient care are, because that's the ultimate longer term goal for this. So I'm going to talk about some positives now. What are ambulance trusts doing? They are doing a lot. Here's one from South East Coast Ambulance Service. They've gone down the path of having a wellbeing hub, as has East of England here. Simple philosophy: ensure staff and volunteers have the support they need. So this is all staff, not just paramedics, and in turn are best placed to meet the needs of the patients in the community, because that's what this is all about. East of England again is very active in this space and has some fantastic initiatives for their staff. NHS Employers likes to go down the case study approach, which I think is really neat. There are 3 from ambulance trusts, so they can say what worked for them. So these are just a couple of pages long, but they give us some really good leads to unpack this and see, well, why do they think it worked, and can we replicate that elsewhere? And often it's really simple things. Their top tips are pretty simple. Listen to what your staff are saying. Actually, it should be ask your staff first, then listen to what they're saying. Simple, but so important. London Ambulance Service have been the leader in this space for a long time, but they know they've still got many challenges to come. But they have a fantastic stress management policy. It's really down the surveillance end, not the reactive management end. They have all sorts of ways where they monitor the temperature of their staff and try and identify those hotspots early so they can intervene early. But they themselves will be the first to say they're not. Is it reaching everybody? Is it really having an impact? What should we continue? What should we discontinue? It's a big agenda, there's a lot to be done, but we've just been blown away by the interest in this, to say clearly people want to engage with doing research in this, which is fantastic. And we've had some subsequent follow-up conversations, actually with Department of Public Health in Wales, who really like this approach and are saying, can you come and do this for the acute sector? We know we've got to unpack this. So it's good. We think this can be a model that can be used in all sorts of different settings. And I just want to finish now. I said at the beginning I wanted to look to the future, because I think that's critically important, and critically important for UEA School of Health Sciences, which is a large trainer for the region. What are we doing? Perhaps what could we do a bit better? Very timely, again, many of you will have seen this report that was released just a few days ago. We see these reports periodically, but this was a really nice one, I thought. It distilled a lot of the existing evidence and did some really nice qualitative work with nurses as well. Coming back, is it money? Is it mindfulness? Is it training? Interestingly, number one reason why nurses are leaving, and you would have all seen the stat that more nurses have left than joined, number one reason is working conditions, staffing levels, workload. Actually, the bottom was pay and benefits. So, of course, money matters, but so much more matters to staff, so much more impacts on their decision to stay in the profession. And as we're seeing, so much more impacts on their decision to join the profession. So it's not all about money. It seems like the easy solution, but it's not the whole story. Many of you will be very engaged with this new discussion document that's come out. So, of course, I read this with great interest to see, where's staff health and wellbeing? And, of course, it's in there. Not as prominent as I would like, so I think that would be my feedback. But clearly there's been a lot of activity in this space in terms of recruitment and retention of the nursing workforce. Clearly leadership development is crucial. Modernising and promoting a positive image, so crucial. Compassionate work environments. Really key thing here is self-compassion as well. Absolutely critical to maintain your own well-being and be able to provide that degree of care to others. And of course, promoting and supporting the health and well-being of the workforce. These are all strategies that have been nominated as being essential for both recruitment and retention. And again, there's lots of organisations that have got various strategies and approaches for doing this. Will it make a difference? I debated whether to show this because it is quite a negative and, in some ways depressing story. Did any of you see this story on BBC? Yeah, so this very brave young woman, Mary, chose to tell her story to the BBC. Just briefly, she was off work for a couple of months due to depression and left the NHS due to job stress. She'd been there 2.5 years. 2.5 years. And I think I didn't want to show the video, but a couple of stills will do it. I'm just really sad I can't be a nurse in the NHS without sacrificing my mental health for it. No worker should be required to do that. Nursing, it's expected that they'll be givers and compassionate. Everybody has a limit. So the question for me is, what can we learn from this? How can the nursing profession be resilient and learn from this challenge? Did this outcome have to happen for someone like Mary? We won't talk specifically about Mary. She's just an example. Somebody like Mary, young, new to the profession, hit her first working job and just went, goodness me, where have I found myself? So how are we preparing our future health professionals for their life in the NHS? It'll never have enough money. It'll always be stressful. How are we getting them ready for it? And thankfully, again, this is such good timing for me, Public Health England, when I arrived, had started a project on this very thing. How is work and health covered in health curricula? What are we teaching our nurses? What are we teaching our allied health? What are we teaching our doctors? What are we teaching our dentists? Is it up to speed, and is it consistent with our modern theories of job stress and how you thrive at work? So just quickly, they covered all the medicine programs and a fairly small sample of nursing and allied health, although they say they had reasonable coverage. But we can see that only a minority of courses are actually covering this as specific objectives. Some are covering management skills but aren't linking that to the health and work agenda. 2 courses out of the 23 they reviewed in nursing had specific objectives around self-care and resilience, and yet that's going to impact on every day of their working life. What I was absolutely delighted to discover when I got here is this is a very, the importance of this is very much perceived in the School of Health Sciences. There are a lot of people interested in this. There are a lot of people wanting to see how can we build on what we've got, how can we make a coherent offering across all our programs to our students that matches best practice and articulates with what they're going to experience when they get into their workplace. What are we teaching them about how to create a positive work environment? If they're lucky, they'll hear about that when they start their job. How are we preparing them to engage with that agenda? Again, this is a big agenda, but I think is utterly critical. So we have this better ability to have a seamless transition, or as seamless as we can make it, between how we prepare our students and what they'll encounter in their first jobs. Almost finished. So where am I going with this? What do I see? Well, hopefully I've convinced you that the integrated approach seems to offer promise. It's come from 30 years of research. I'm not going to argue with that. But we really need to have some way of monitoring the implementation and evaluation of this approach. See where it's working, where it's not, and see how we can distill best practice. Critically for me, this has to be a sector-based approach. I think it just makes sense. So that means looking at ambulance trusts, for example. It means you engage with local challenges. There'll be efficiencies because what you do for a paramedic is almost certainly going to help for a call handler and for other people in the organisation, so why not address it coherently? And really importantly for me is it's inclusive of all staff. I absolutely value that certain things may be done for certain professions, but again, some of that underlying infrastructure you'll have to support health and wellbeing is going to support everybody, so why not take that focus? And I raise this because some of you might have seen the fantastic initiative that's come out of the National Academy of Medicine in the US, where they've got a clinician wellbeing and resilience, massive national push at the moment. It's fantastic. It's clinicians only. Yes, they're a high-risk group. Everybody else working in the sector has got troubles too. So that's one model, and I think it's good to get traction, but I think when you take it down to sector level, we're going to be more efficient and hopefully more powerful. Final message, consistent messaging and building what we call work health literacy from day one. As with any learning approach, you start with what people can absorb when they're ready for it, but people are out on placement pretty quickly. We know if they come into an environment where perhaps unfavourable behaviours are tolerated, where things aren't said, people will gradually conform to that environment. So making them active agents in building a positive work culture, we can start that early. So to finish, so some of you might recognise this as my social media photo that I put on everywhere. What I'm now revealing is that this was when my husband Richard, who's been in Norwich for 1 week, it's been a long year, Our first trip to a pub, he of course Australian, loves a pub. This was a little selfie in a pub showing our happy beaming faces that we were actually getting a chance to spend time together. So now when you see my social media photo, you can go, that was a sneaky pub selfie, I'm on to you. But I just wanted to express a particular thanks to Richard, because it has been a long year. Thankfully, he loves Norwich as much as I do, so we're now here for the long haul, which is good. So yeah, thank you very much for your time. I hope you found it interesting, and I hope you can stick around for a chat and a drink afterwards. Thank you.
Lovely. Thank you. Thank you very much, Kristy, for an informative and an engaging lecture. Good evening, everyone. I'm Roslyn Jarrett, and I'm the Dean of the School of Health Sciences, and I have the pleasure of working with Kristy. Is that part of the evening, before we can relax and chat to you, that there's an opportunity to ask some questions or make some points or ask Kristy for some advice, actually, for a few minutes before we break up and have a drink. I just wondered if anyone has got any questions. Oh, we have one. Thank you.
First of all, Kristy, Amanda Howe from MED, thank you so much. That was a really wonderful talk. I found it moving because, you know, I've worked in the health service a long time, and sometimes it works well, sometimes it doesn't, so thank you. My comment, one quick comment, one of your earlier slides that talked about the National Health Survey, don't think it mentioned primary care sector staff. And thinking about it, you know, there was community trust, there were acute trusts, there were ambulance trusts, and I'm thinking, we do this in primary care. Have I ever had a survey about my view on wellbeing? There are some services, I know we won one for GPs and wellbeing practitioner health program, but maybe we could watch that space and check that one out, because if it is a gap, what are we doing?
You're exactly right, and it is a gap. There is the ability, as you've mentioned, for individual organisations to sort of engage with it, but because it's not centrally supported, it doesn't have, as far as I can tell, the resourcing behind it like the other areas do, where they have a very slick operation, where they get their reports quite quickly, where the data is then made available to researchers. So you're absolutely right, that's a huge gap. Absolutely, because we also know that the challenges in terms of recruitment and retention in that sector are possibly even worse than nursing. So absolutely, yeah, it's a good point.
And my other question, if I may, was more about educational methods. So there's an offset, isn't there, between telling students about issues and telling them and getting them to have a lived experience. So I think we've tried quite hard in the MBBS course to sort of focus on things like, you know, what makes a team work well and different roles and professionalism, but I'd still, you know, value maybe be a conversation about how we embed this into the lived experience of being a student as people come through the professional courses.
I think that's actually critical and fantastic you say that, because we have got some sort of work in development that's being led by the business school, actually looking at how we can do better simulations of stressful environments and how we can actually sort of embed those skills of responding with ethical and appropriate behaviours under stress, that you can teach that in innovative and interesting simulation ways, but it's done in a fairly patchy and sort of inconsistent way. But I think a point I'd take further is we should be doing this actually broadly across the faculty, because there are pockets of excellent work going on, but from what I can see, not so much linked up activity. So again, another opportunity for us to be really distinctive in this space. Hi, Richard.
That's brilliant. Thank you very much. My name's Richard Gorrod. I'm a GP, and I've been a doctor for 31 years when I guess the wheels came completely off the bus, and I became very depressed myself. I was suicidal. I ended up in hospital for 4 months. Basically, it was bloody awful. Okay, come through all of that, come out the other side, and in recent years, the last couple of years, I've actually got involved with educating students, medical students, and I've actually been coming up here and I've educated all the students, I think year 1, 2, 3, 4, 5, and the latest lot of one as well, and at University of Cambridge. I've also got involved with the same thing, with just sharing my experience Well, we're quite happy to, or we will experience physical illness and sort of not take it upon ourselves. It's just one of those things. And when you become mentally ill, having previously been mentally well, you sort of, you don't take it very well. All I would say is, I sometimes still get the feeling that there's a bit of lip service to, we need to get somebody in just to sort of tick the box. And I don't always feel like I'm actually sort of engaged as well as I think I should. And it's not because I've got all the answers, because I haven't. But I think my lectures to the students have actually gone down reasonably well. I think because, if you like, there's some resonance that they think, well, oh my God, it happened to him. Maybe I'll listen to it now. It's worth listening. And I think self-care, it's so important that we teach our future health carers how to look after themselves.
Absolutely.
I mean, one of the things that I remember, and I think is a good sort of thing to remember for everybody in the audience, is I was in hospital, and when you're on an aeroplane and all the oxygen masks fall down, the advice is very much to put your own on first before you go around and help your next door neighbours. And when I was in hospital, there were a few doctors there, and the experience was the doctors who are in hospital that have had mental health problems, we're the ones that actually don't put our own oxygen mask on. We actually put everybody else on the aeroplane, and then we keel over when, anyway.
I think that's a beautiful analogy, and I would just absolutely reiterate that there are still, and this, again, we've seen this in the media recently, profound structural barriers, particularly for medical doctors disclosing and speaking up when they're struggling. Absolutely. And I know Amanda and I have had a chat about that.
I have one quick question. I seem to, first of all, there are lessons and key messages in your lecture for those of us in academia, as well as in the NHS. And I seem to recall there was a survey done, but it might have been more than 10, 12 years ago, of stress in higher education. Does that ring a bell with you at all?
They are pretty much done about every 10 years, so that would
Every
be
10?
about...
Right.
I mean, I'm being a bit glib.
Yes.
Yeah, certainly when you've seen them, there'll be focus.
It's what actions we've done as a result of them, really.
Yeah, exactly. And again, I think coming back to Richard's point, moving beyond that lip service,
Yes.
the number of times when I go and speak to employers and I hear, oh, but we've done mental health first aid training, we tick that box. Oh, when was that? 2 years ago. How many people attended? Oh, about 10%. Oh, okay, do you really think you've ticked off that mental health box? So I think we do have to be careful that, of course, doing visible things is important. It helps people discuss, but we need to make sure the systems are in place. And it sounds boring, but policies are so powerful in this space. If you have a mental health policy that's reported at board level, things will happen and things will be reported publicly. So, yeah.
Good point. There was one other question. Oh, sorry, yes. Fiona.
Hi, Kristy. That was a great job of connecting us both locally, regionally, nationally, internationally, with the kind of the up-to-date scene of these issues. Of course, the classic Whitehall studies conducted by Michael Marmot in two big studies 20 years apart, located the paradoxical finding at the time when we thought that it was top executives who could have got no stress, that actually the people with the least power and less control were more likely to experience these effects. And the second survey really underlined the mental health effects. And I was just wondering where you find in today's working conditions in the NHS, when there's more uncertainty, more pressure, less control over the various demands, how that's intersected with the kinds of measures that you're suggesting.
Yeah, I think it's absolutely critical, and of course that was a landmark study. The integrated approach built very heavily on the Whitehall series of studies and those that were replicated in other countries as they were done. There's no simple and easy answer I can give to what you've raised, Fiona. As always, what you've raised is at the heart of the matter and difficult to answer. But I can only say that when we do know that there is some surveillance of things that matter, we know that in some areas it's trending right and in some areas it's not trending right. We are asking staff about how empowered they feel. What's then done when staff are saying, no, I'm not empowered. I can't speak up about errors. I can't report harassment, whether it's from staff or patients or the public. What's then happening and what are we doing to address that? That seems to be the bit where we've got snippets of understanding, but there is no national surveillance approach to that. And again, coming back to being an epidemiologist, I think surveillance is the answer to everything. Of course it's not, but it helps fill in those gaps about where it's working and where it isn't.
Yes, at the back.
Yeah, there was a quick correlation, thank you very much. One you qualified nurse. You said towards the end that the School of Health Sciences has been really quite forthcoming with their other practices of implementing and teaching resilience and really trying to help their nurses to be prepared when they go into their job. Yet, I don't know what other ones there are, but for instance, in the very last module there's things of resilience reflection, and it's our assignment of search improvement and change board culture, which are very critical things. Yet they're actually in the very last 3 months of our degree, or actually on placement, working with those in that last week anyway.
Yeah.
So that in itself isn't exactly the most resilient building. But at the same time, we've actually already had 15 months at total time of placements, whereas nursing students, we're on the wards, really amongst the ward itself. And time again, you're very much pressured into becoming part of that ward. And so it can be very clicky, it can be very all-encompassing, and so it's very difficult for a student, a student's relationship, along with the rest of your healthcare assistants and seniors to try and work alongside, yet have the courage enough to come out and say something's wrong, or I need help, or you're doing something that's actually combating patient safety. And so where do these implementations come in throughout the course? Well, if they come into the last 3 months of our placement, we're already acclimatised, already numb, for instance, to that resilience and things. And so I'm very lucky in my new job, and I'm loving it, I'm soon doing it for advance, very well supported. Yet I've got colleagues who are now, they're their 4th week into their new job, 2 weeks of inductions, 2 weeks now actually working in the department, and they're crying on the daily, and they're no longer supernumerary, they're part of the unit. They're counted in the numbers, and that is not the right way to build resilience and actually try and cope in their new job.
Yeah, thank you. I think that's hugely powerful, and you've said it much better than I possibly could because you've lived it. I agree absolutely with everything you've said, and I think that's precisely why those that are looking at this in the school at the moment are trying to work out exactly those issues. When can we start communicating this message and preparing people, because you are living those environments very soon after you start, and you're exactly right, getting some skills and tools in your last 3 months is perhaps not the most useful approach. We're holding a curriculum review workshop in a little while on this. I think you should come and tell your story. This is exactly what we need to hear. Thank you.
Very much so. Just one last question, and then I must bring it to a close.
Thank you so much. I just wanted to say it would be really interesting to look at this more for our where we all live and work. It's a very interesting county to be in. We are so spread across the county. I work for the community trust, and actually you haven't always got that support. You are out on your own. We have district nursing. I was a district physiotherapist, and you're out there with the most challenging of patients and relatives. And actually you don't have a central place to come back to. There isn't a big shiny building and a big atrium to come, and environments like this to come and chat about that. And actually it'd be really interesting to look at our workforce out there is actually having to look at sort of the diverse population who's all over our county. We actually haven't got that support of colleagues on a daily basis. We haven't got good connectivity to even send a text sometimes to get that support. So actually, how can we build the resilience of staff actually who aren't in that ward environment as well? I think it's actually for new staff. I've got colleagues only 5 years qualified. They're no longer nurses, physios, OTs.
Hugely important point, and again, thank you for sharing. Your work environment travels with you. You're exactly right. And it's a really good point that I'm going to continue on, because a lot of what we know about job stress and how we manage and prevent it does come from building-based work environment research, because it's easy. It's easy for researchers to go in with a pretty much captive audience. But you're exactly right. Your work environment is the big wide world out there, and how can we better build supports for you and encourage that sharing and connectedness? Because we can, there will be ways. We need to find where it's working and see how we can make it work. But I also love bringing it back to our beautiful part of the world that we live in here, which I'm a full convert, as you might have noticed. It is a beautiful part of the world, so let's become distinctive in helping people maximise their well-being in this lovely part of the world.
I mean, I hope we can carry on that conversation, Kristy, over some wine or non-alcoholic drinks, whichever one would like. I would like to just finish. One thing that came to me was the integrated approach that you said, and I think the words that I'm going to take away are about promoting the positive, preventing harm, and managing illness. I think they're quite important messages to take away. But on behalf of us all, I'd like to say thank you very much for your time and for the lecture this evening. Thank you.
Thank you.